Can you all still see the screen? I'll take that as a yes. Okay, I'm just going to give it 10 more seconds to let a couple last people filter in here. All right, I think we can get started. So hello, everyone. Thank you for joining us today. My name is Danny McDermott. I'm a third-year law student at the University of Arizona, James E. Rogers College of Law, and I'm also a digital health research policy fellow here with the Center for Telehealth and eHealth Law. That's a mouthful. So CTeL is a nationally recognized 501c3 nonprofit research organization focused on telehealth and virtual care issues. CTeL conducts research on a wide range of telehealth related issues, and part of that research involves 50 state surveys like the one we'll be presenting today. So that said, while this presentation is meant to provide a general roadmap of telehealth prescribing laws across the country, it's only focusing on non-controlled substances, so the prescribing of non-controlled medications via telehealth. And off the bat, I'd like to emphasize that we recommend that you consult with legal counsel if you're interested in a legal opinion on the laws of any given state. So with that disclaimer out of the way, I hope that this presentation will be useful for you all, whether you're a provider or administrator, educator, or in any way, in any role relating to the provision of telehealth services. Just as a starting point, with the increasing prevalence of telemedicine and the constant advancement in medical technology, understanding and adhering to prescribing requirements is becoming more and more challenging. So to that end, myself and CTeL have conducted a review of the prescribing laws and regulations pertaining to non-controlled substances in all 50 states, DC, and Puerto Rico. As a general overview, federal law, mainly the Ryan-Haight Act, generally governs the prescribing of controlled substances, with some state law variation within those bounds. But in contrast, state law largely governs the prescribing of non-controlled medications. Going into depth on federal law requirements for prescribing controlled substances through telehealth is beyond the scope of this presentation and not addressed in the report, which is currently available to CTeL members. But in short, under the Ryan-Haight Act, a practitioner can prescribe controlled drugs to a patient only after conducting an in-person evaluation, subject to a handful of exceptions. During the pandemic, the DEA relaxed those requirements and allowed for providers to prescribe controlled drugs via telehealth encounters, even where they hadn't conducted an in-person evaluation, just to try and prevent lapses of care. However, the federal rules in that area are currently under review, and in fact, the DEA has released proposed rule changes aimed at prescribing controlled substances through telehealth, trying to balance patient access and safety. And in fact, CTeL representatives spoke at the DEA listening session last week, trying to solicit comments and feedback on the proposed rule. And CTeL will absolutely keep its members informed on the status and impact of those proposed rules and their development over the coming months. So back to the topic at hand. States often address the rules and requirements for the remote prescribing of controlled substances and non-controlled substances separately. So also keep in mind that these interactions or these prescriptions are governed by the law of the state where the patient is located in. So say you're a physician or nurse practitioner located where I am in Arizona and you're engaging with a patient in Oregon, you would have to follow Oregon's requirements, though your home state, so Arizona, your home state's licensing board may have its own additional requirements that you'd have to abide by. So providers have to be aware of the laws in both their home state and the remote state that the patient is located in. And again, just having an understanding of state laws regarding the prescribing of medication via telehealth is They're crucial for practitioners because it governs how and when they can prescribe medication. And they describe how to form a provider-patient relationship, which is a prerequisite for prescribing in all states. So these rules and the rules that we'll cover today come from a range of sources. We have state statutes, state administrative regulations, and state medical board policies. So on that last point, although state medical board policies or guidance documents don't have the force of law that statutes or regulations do, I think the clear expectation is that they'll be followed, or at least provide answers when the law is unclear or confusing. Before we jump in, I also want to highlight that the requirements we're going to discuss today pertain to a provider's first time interacting with a patient. As a general rule, if a provider has a pre-existing relationship with a patient, they're going to have more flexibility when it comes to prescribing. So keep that in mind as we go forward. So with that introduction done, what exactly is in the report? The survey, I'm going to call it survey report interchangeably. I use those terms interchangeably over the course of the presentation, but the survey attempts to anticipate common questions from practitioners related to the prescribing of medication via telehealth. And it tries to lay out what a practitioner would need to know about prescribing non-controlled medications through telehealth in each state. We also tried to format the report in a digestible way that provides access or links to all the relevant laws or guidance on point in a given state, and tries to boil down that state's requirements by answering several of these key questions that you see on screen. So first, we have whether a physical exam is required before issuing a prescription to a patient through telehealth. Somewhat relatedly, whether a provider needs to have a pre-existing provider-patient relationship with the person before they can prescribe drugs to them via telehealth. How a provider can go about establishing that provider-patient relationship, whether the provider can conduct physical exams via telehealth, and if so, what are the requirements for said exam. Additionally, we also addressed whether states allow providers to use kind of like online questionnaires as a sole basis for a prescription. And then lastly, we addressed some common exceptions that are written into state law regarding specific limitations on what can and cannot be prescribed via telehealth. We're going to go through each of these areas in turn today, and I'll try to provide a high-level summary of the general answers to each question across the country. I'm also going to highlight some representative language from states as we go, but I won't be delving into the laws of each state in particular, just because we don't have the time. But if you do have state-specific questions, I direct you to the report, which again is now available to CTeL members. Without further ado, let's jump into the first question. So first, we're going to deal with whether a physical exam or a pre-existing provider-patient relationship is required before issuing a prescription via telehealth. At a high level, 26 states and Puerto Rico do not explicitly require a physical exam or pre-existing relationship for prescribing non-controlled meds via telemedicine, which leaves us with 25 states that do prohibit prescribing non-controlled substances without either first conducting a physical exam or in absence of a pre-existing provider-patient relationship. Pre-existing here meaning that, again, the provider and patient had a relationship before the telehealth encounter that led to the prescription. Some states are vague and don't explicitly require a physical exam, but they might require what they call an appropriate evaluation and require the provider to review the patient's medical history. Also, as we'll see a few slides on, some states will explicitly require a physical exam, but then provide no detail on what that exam looks like. By way of comparison, an example, we'll compare a couple of states that fall into these two buckets. So Arizona on the left considers it unprofessional conduct to prescribe medication without conducting either a physical or mental health examination unless a doctor-patient relationship already exists. And then on the right, in contrast, Florida doesn't require a provider to conduct a physical exam or research the patient's medical history if they can glean enough info to diagnose and treat the patient through an evaluation. I'd like to try and add a little more context and nuance to the requirement of a physical exam or provider-patient relationship. Again, generally speaking, a provider in each state is going to require a provider-patient relationship in order to prescribe medications to a patient via telemedicine. That said, several states allow providers to establish that relationship via telemedicine. So among states that do not require a pre-existing physician-patient relationship, it's fairly common that they nonetheless require that the physician verify the identity of the patient, disclose their own identity, and then perform an evaluation sufficient to determine a diagnosis and treatment plan for the patient. So in those states, it would be possible for a provider to meet a patient for the first time during a telehealth encounter, establish a provider-patient relationship during that encounter, and then to diagnose and prescribe medication to that patient during the same visit. And I think this language from New Mexico on the right here is particularly representative of this approach. So New Mexico law provides that a pre-existing physician-patient relationship is not required prior to prescribing drugs to a patient if the treatment or recommendation is made during a face-to-face telehealth encounter using standard video conferencing technology where a medical history and informed consent are obtained and a physical exam is performed or not normally required for the specific services being provided. Interestingly enough, while a provider-patient relationship is a prerequisite for prescribing, a report found that only 24 states actually define the phrase provider-patient relationship or a similar term in their statutes or regulations or board policies. The states use various names for this relationship. So it could be licensee-patient relationship, practitioner-patient relationship, provider-patient relationship, physician-patient relationship. But regardless of which terms they use, there are some common elements among how they define the relationship. So the most common requirements or steps needed to establish a provider-patient relationship are that the patient must verify, or the provider must verify the patient's identity, and then the provider has to disclose their own identity and their own credentials. There must be some informed consent to treat the patient through telehealth, and some states say that this relationship must include an evaluation of some sort, or at least reviewing the patient's medical history. So that last requirement, that last one, is highly variable across states. Moving on to what a physical exam might look like from state to state. In states that more thoroughly describe what a telehealth exam must look like in the context of issuing a prescription for non-controlled medication, they often include some combination of requirements listed at the bottom of the screen. So it's common that a state will require that an exam include taking or obtaining a medical history, establishing a diagnosis for the patient, and then discussing with the patient that therapeutic plan that the provider formulated. And then lastly, ensuring that follow-up care is available. Usually either in-person follow-up care is available or follow-up care that's equivalent to what would be available to the patient if you were seeing that person. So you can see here that Oklahoma kind of checks all of those boxes and requires a patient history, a physical, a diagnosis and treatment plan, and then making sure that follow-up care is available to the patient. If a state doesn't specify the exact requirements of a telehealth exam or patient evaluation, as some states term it, it's still likely that some provision of their state laws or regs requires that the examination meets the standard of care as would be required for an in-person visit or examination. So basically, the exam has to be equivalent to an in-person evaluation. And it's generally true that if a provider deems that a telehealth encounter doesn't meet that standard, then they're required to arrange an in-person visit. Moving on to the use of online questionnaires. Most states say that a static questionnaire process by itself is an insufficient basis for a prescription. So more specifically, 36 states explicitly prohibit prescribing non-controlled medications based solely on a medical questionnaire or solely on a patient's applied history. That is somewhere in their laws or regulations or board policies that specifically say that a provider can't issue a prescription based solely on what a patient reports in response to like a static online questionnaire. Keep in mind that that number, that 36, just captures states that explicitly prohibit the use of questionnaires by themselves. It's likely that other states fall into the same bucket, but do so in a more roundabout way, like through the state's requirements for either a physical exam or evaluation, or their requirements for how you establish a provider-patient relationship. So even in states that don't explicitly call out the use of questionnaires, it's likely that further steps are going to be required on the part of the provider or the patient before issuing a prescription via telemedicine. And there's some representative examples from North Dakota and South Carolina on the screen. And these provisions are usually short and sweet. But before we move on, I'd like to note that asynchronous care like this, like using online questionnaires, is becoming more common. I'm sure we've all seen commercials for services where you can go online and fill out a questionnaire and get prescribed medication for a range of afflictions. It's just important to note that those organizations and practitioners that work for those organizations should be mindful that prescribing just on the basis of questionnaires is not allowable in a healthy majority of states. So somewhat surprisingly to me, as I was going through compiling the report, doing research on the states in Puerto Rico, was that Illinois, New York, and Puerto Rico are silent on specific requirements or restrictions for prescribing non-controlled medications via telehealth. Now, this doesn't mean that these state laws are silent on telehealth use in general, or that providers in these states can't use telehealth to prescribe non-controlled medications. It just means that the state's laws, regulations, board policies don't provide any detail on the requirements for prescribing non-controlled medications via telehealth. You can see here that Illinois statute includes some broad kind of umbrella language governing telehealth services in general. And in my reading of the statute, it doesn't prohibit prescribing non-controlled medications via telehealth, so long as doing so is within the provider's scope of practice and done in a way that would also satisfy the standard of care for in-person services. So if you are providing telehealth services or prescribing via telehealth to patients in these states, we highly recommend that you consult with legal counsel familiar with those jurisdictions. And then lastly, states can and do adopt some specific limitations on what can be prescribed via telehealth. The most common instances we found in the report were for medication-assisted abortions and medical marijuana. So, for instance, several states, mainly in the South and Midwest, provide that abortion-inducing medication can only be issued in person or in the presence of a physician. And then similarly, some states that don't require an in-person physical exam before prescribing in general might then go and require an in-person physical exam before a provider can issue a medical marijuana prescription to someone. So it's important to note that if you familiarize yourself with the state's baseline laws regarding how and when non-controlled medication can be prescribed through telehealth, it's always going to be important to consider whether the state has adopted any express exceptions to those general rules. And those exceptions are often or might be found in other standalone sections of the relevant statute or regulation. So I hope that was a useful summary. Again, it was a high level tour of the information contained in the report. There's a handy executive summary at the start of the report and a table that categorizes states categorizes states based on their approach to the topics that we ran through today, which is a helpful reference, at least for me. We tried to squeeze it all onto this slide, but it's a little small. Again, if you have specific inquiries about a given state's approach, the individual state profiles in the report will summarize and link to the relevant laws or regulations on point for that given state. Also, keep an eye out for more CTeL reports coming in the coming months. CTeL has 3 other policy fellows who are currently working on reports involving licensure compact issues, telehealth reimbursement, and a complementary report to this one that looks at the prescribing of controlled substances across states. So thanks to the other fellows for their help along the way, and thanks to Professor Tara Sklar at the U of A for her advisement and feedback along the way. And at this point, I think we can open it up to questions. I think you can either, if you have questions, you can either come off mute and shout them out or throw them in the chat and I'll parse through them. So thank you. If you also have questions after the Zoom ends, we'll have a recording of this presentation available online, and I think it might be sent out to you. And you can also reach out to us at info@ctel.org. Thank you. Absolutely. Ooh, sorry, I'm just seeing that my audio is going in and out.
I think so far, yeah, I think we can hear you pretty well, Danny.
Okay, sorry about that. I was in the zone. If you want me to reiterate anything, I'd be happy to do that.
We have Dr. Sklar on the phone, who's also an advisory board member to CTeL with the University of Arizona School of Law. And we are grateful for her leadership. Do you have anything to add to Danny's presentation?
Oh, I just think congratulations, Danny, and to Krista at CTeL. I think this came out really, really well. It was about maybe 9 months in the making from conception to the report. So, which you did while being a full-time student and working part-time. So I'm just really impressed with what you pulled together. I'm particularly interested in the states that are kind of these outliers with some of the particularly at the end there when you mentioned medical marijuana, and it's just as well as abortion-inducing medication, but those are very different different types of legislation. Because I think in some states, you know, it can be, maybe you saw this in your research, like that nice contrast between New Mexico and Minnesota per se around medical marijuana and how to prescribe it. Just be interesting to see over time to revisit how these laws are changing in those areas. And maybe actually you have some insights, given that you really were in the trenches looking at how states may vary regarding some of these more controversial prescriptions.
Yeah, that's right. I mean, I'm involved with the policy group that CTeL puts out every Friday, in which we track developments in state law and federal law. And over the past year, I was surprised at how often we came across bills at in state legislators across the country involving telehealth and medical marijuana. And even in putting together the report, you saw different approaches. Like some states, I don't want to misspeak and name a state because my memory is failing me right now, but some states might require physical exams for the remote prescribing of non-controlled substances in general, but then include an exception saying that no, you can use telehealth to perform a physical exam before prescribing medical marijuana to a patient, whereas in other states they might say in general an in-person physical is not required before prescribing. However, an in-person physical is required before prescribing medical marijuana. So it's just interesting.
Danny, we have a question here from Abby Worthen. Abby asked, do any state laws delineate by clinician type and who may teleprescribe?
So states do definitely regulate what types of providers can provide telehealth services. Oftentimes in their statutes or regulations, there will be a long list of the classes of providers whom can provide telehealth services. So that would be one way that they regulate the types of clinicians who can prescribe via telehealth. Another important thing to consider would be that these clinician types might have their own governing board or body within the state, which issues its own policies or guidance on teleprescribing. So it would be important to be mindful if you were, I guess for any clinician type, be mindful of the specific governing board in your state that regulates your profession and see what their stance is on teleprescribing. So I'm sure that some states do delineate which types of clinicians can teleprescribe and which can't.
We've received a lot of questions over the last 6 months about asynchronous companies. They're becoming more prolific. And the question is, well, how are these companies operational if the laws specifically state that you cannot engage with a patient for the first time encounter using a medical questionnaire? Do either you or Dr. Sklar have any thoughts on that?
I have an anecdotal thought. So I know of friends who have kind of like submitted questionnaires for medications, and then because we're in Arizona, which requires an examination or establishment of a provider-patient relationship, the organization would reach out to them and schedule a telehealth visit. So it seems to me like they are cognizant of the prerequisites to prescribing. I'm probably aware that the use of online questionnaires as the sole basis for prescriptions is generally frowned upon. Professor Sklar, I don't know if you have any other thoughts.
Sure, I was just nodding along. I think that was well stated, and that is the case in Arizona, that you can have a telehealth visit even over the phone. I think it's an important distinction because not all states have this. Over the phone, audio only can serve as a telehealth visit, and that can have a factor of certain population groups that are trying to access prescription drugs. If they're not able to have a live video telehealth visit, is audio only an option? And that can be further impacted by how reimbursement works. Half the states, audio only isn't at parity with Medicaid and other private payers. So that could be a factor. And well, let's just schedule a telehealth visit so you don't do this online survey screening. But if you're not doing audio only, that can limit certain groups of certain patient populations in particular states. So just to add that nuance to what you said, I think is important.
I think we have a question from Jaslyn. Jaslyn, if you'd like to go on audio and ask your question, you can, or I could ask it for you.
Oh, I see it. Any notable differences and restrictions for pediatricians and child psychiatrists, etc.? Was that the question, Jaslyn?
Yes, I'm with the American Academy of Child and Adolescent Psychiatry. And so I'm just wondering if you noticed any general differences, trends, anything like that over the results of the survey.
Not that I can speak to. And that's not saying that differences and the restrictions don't exist. It's just that I don't think I was going through state laws with a fine enough comb to pick up on any difference between specifically pediatricians and child psychologists.
We might actually see that, Jaslyn, in the CTeL's upcoming report looking at the prescribing of controlled substances.
Gotcha.
Oh, that would make sense. That I was wondering, Danny, with this bird's eye view you have of the data, were there any regional tendencies that you noticed between like the Southwest and Northeast or Southeast, where states kind of grouped together with their policies, or did it seem very much each state doing their own thing that may or may not align with adjacent states? Go ahead.
Yeah, surprisingly, no, I didn't get a sense that there was any sort of regional consistency in how states approached teleprescribing of at least non-controlled medications. I think that you might be more likely to see that in the realm of prescribing controlled medications, but no, other than the use of telehealth to provide abortion-inducing medications, which tended to be more common against states in the Midwest and South. That was the only real trend that I picked up on. So no, unlike some other things, I'm not sure you can use region as a shortcut to try and guess what the state's laws are.
And something that might be of interest to those that are on the call is CTeL in the coming weeks will be releasing its state-based chapters. So we will have chairs for each of the regions, and we will be focusing more keenly on what is happening at the state levels and ways that we could help you become your own advocates within your health systems or institutions to change policy that you might not necessarily agree with.
I see a question from Beju. I'm sorry if I'm pronouncing that wrong.
Hey, no, Danny, that was actually perfect. Thanks for calling me out there. Beju, I'm a pharmacist actually with DoxyMe, and one of the things I talked about is prescribing. So I really enjoyed that talk about some of or report actually about some of the nuances going on here. I actually attended a session in the Northeast pretty recently, and it was quite insightful. Speaking about how states and regions kind of trends kind of come together. Maybe there's a bit of peer pressure involved between some regional areas, but it was interesting because I picked up on some of the minimum requirement, minimum required modalities for prescribing non-controlled substances in states. And so if you look at the Northeast, about half, the minimum requirements were on asynchronous tools or modality, and then the other half were, majority silent in terms of modality. And in 2019, I believe, looking at New Hampshire specifically, the minimum requirement for New Hampshire in 2019 was audio video as a minimum requirement. That actually changed this year to asynchronous. And so I'm wondering if you're seeing a trend towards more, speaking about asynchronous tools in general, but are you seeing a trend in general for this minimum requirement in modality for prescribing non-controlled substances?
I think so. This report was more of a point in time project for myself, but having worked on the policy scoop for CTeL for the last year and a half, bills at the state level either allowing for asynchronous or audio only telehealth, the provision of audio only telehealth services were becoming more common, likely in response to the pandemic. Again, I think a bill in Congress was just released last week, providing for the reimbursement for telehealth services out of federally qualified health centers and health clinics. And in the text of that bill, they were saying that yes, we're going to reimburse for audio only services provided at these sites. So yeah, my sense is that the trend is towards becoming more allowable towards either asynchronous or audio only services.
Awesome, thank you. And so it's not just peer pressure, but there's definitely a little bit more at work here.
That's my sense.
Yeah, thank you so much.
Perfect, thank you. All right, anything else? Again, the full report is available to CTeL members now, and I think it would be more helpful than my regurgitation or limited memory of specific state laws if you have state-specific questions. And I think it's a great resource for practitioners or administrators or educators looking to get a sense of the state's laws regarding the prescribing of non-controlled medications in a given state.
We will be showcasing Danny's research at the CTeL Summit, which we are honored will be taking place on Capitol Hill on December 6th and 7th. So there's a great deal of interest by policymakers about what do each of the states say, how do we ensure quality? And so Danny's research will be showcased on the Hill on December 6th and 7th. So if anybody else is interested in joining us, you can go to ctelsummit.org, and you are invited to join us if you are in DC. If you have any other questions, just email us at info@ctel.org, and I will put my phone number in the chat for everyone. This is my work cell. Feel free to call or text. Thank you, everyone. We really appreciate your time today, and we'll look forward to giving you the next presentation in the coming weeks. Thank you, Danny. You did a fantastic job, and thank you, Dr. Sklar, for all of your leadership and the 4 fellows you have helped us gain over the past year. Great work.
My pleasure. This is wonderful, wonderful opportunity for students and graduate students to work with CTeL. So thank you.
Take care.
Thank you, Danny.
Thanks for coming, everyone.